Okay, good morning, everybody. I'm going to talk to you about a very useful topic in case of COVID disaster. This is, first of all, one of the COVID disaster staff training series. I'll talk about critical care ultrasonography, and I'll try to be brief, up to the point. And the reason for this presentation is just to prepare our joining staff for any unwanted disaster caused by COVID. So without further to say, I'll just go right into it. By the way, this presentation is meant to be a refresher to those who have experience with ultrasonography, and is considered an introduction to those who do not have that experience. So tissues are divided into three or four, I don't know, 5 types maybe. In relation to ultrasonography, we have a very highly reflective structures or tissues in our body, and these could be air, because air is the enemy of ultrasonography, like the air inside the lung, and the air produces a white artifact like this, so because it's very highly reflective. And we have also the ribs that produce black artifacts like these. Both these structures, the air and the ribs, are very highly reflective. So this is a chest ultrasonography using a curvilinear array transducer. The ribs, as I mentioned, will produce black artifacts. The air will produce white artifacts. So all what we can see in ultrasonography of the chest are black and white artifacts, alternating with each other. This is how it looks like in reality, and this is a live view of the chest ultrasonography. The other type of tissue is the anechoic tissue, which is the tissue that doesn't reflect ultrasound at all, like water. Any fluid is considered anechoic with different degrees. The lighter the fluid, like water, the more unreflective it is. So anechoic structures produce usually black shadow, like this pleural effusion here. This is the diaphragm, and this is the liver. The blood also is anechoic, so it is black in ultrasonography. Now, hypoechoic tissues are soft tissues in general, and they produce different grades or shades of gray. Like you see, this is the liver of a patient, normal individual, and this is a liver of a patient with metastatic disease. As you see, this is hypoechoic. This is the normal liver, and this is the metastasis. It is more hypoechoic than the liver itself. Then the hyperechoic structures or tissues, like the fibrous structures rich in fibrous tissues, and it is white in ultrasonography, like the diaphragm, like the pericardium, etc. So structures again are divided into 4 types: highly reflective, bone or air, anechoic, like water, it is black, hypoechoic, different shades of gray, and hyperechoic structures rich in fibrous tissue. So let's start with vascular ultrasonography, and we use for vascular imaging and procedures the linear array transducer here, and this is how the transducer relates to the image itself. When we like to cannulate one of the veins, we basically choose mainly the IJ or the internal jugular vein in the right side most of the time. We can use either the transverse or longitudinal approach. This is how the IJ looks like in the left side. You see the IJ. This is the transducer, as you see here, and this is the common carotid. The vein is not circular. It has thin wall. It is easily collapsible compared to the artery, which is circular, pulsatile, thick-walled, not easily collapsible or compressible. Now, ultrasound-guided central venous catheter insertion can be either static, whereby we map the vein and then throw the ultrasound transducer away and do blind or semi-blind insertion, or dynamic, where we can use again the transverse or longitudinal approach live. Now, this is how we do it actually. We use for live method sterile sleeve, and we clean the patient very well, and after we get the vein, we pass the guide wire. So the most important thing is that you put the vein right in the center of the image, and you put your needle right in the center of the transducer, and then you push until you see the needle going inside the vein, you see? And once you get blood back, you put your guide wire in. Now this is a longitudinal approach. As you see, this is the IJ and longitudinal approach, and you will see my needle going right through the tissues into the internal jugular vein. Now the second commonest vein to be cannulated is the femoral vein. This is the right groin, this is the vein, the femoral artery and femoral nerve. And we put the transducer usually here, and this is what we see in live image. This is the femoral vein, as you see, and this is the femoral artery. And again, we put the vein right in the center, and we pass our needle at the center of, or at the middle of the transducer until we see that the needle went inside the vein. I will not talk about subclavian cannulation using ultrasound because it needs more experience and practice. Now, be aware of the fact that you may get very abnormal veins. So a small IJ, like in this particular case, this is the right side. Or when you see a hypoechoic structure inside the vein, then this most likely is a thrombus. So be aware of that. Now, it is very important that when you do a procedure, is that you put the heel of your hand at the patient's body, because this will help you stabilize the transducer. When you use the transverse approach, make sure that you tilt the transducer so that you can see the tip of your needle rather than the shaft of the needle. And when you do the longitudinal approach, make sure that your needle goes right at the middle of the side of the transducer, because the ultrasound passes from the middle of the transducer. Not all of this is ultrasound. And this is how we do ultrasound guided procedure. Now, it's very important that the screen of the ultrasound machine is not to your side or behind you, because it will be very hard to see. It is better that you keep the screen. As you see, this is the operator, this is the patient, and this is the screen right in front of you. It will be easier, more helpful. Now, moving further to thoracic ultrasound examination, and in thoracic ultrasound we have upper chest ultrasound and lower chest ultrasound. Lower chest ultrasound we look for pleural effusion, collapse, consolidation and congestion, and for upper chest ultrasound we look for pneumothorax mainly. Now, for upper chest ultrasound we can use either the linear transducer or the curvilinear array transducer. And what we do here basically is that we put our transducer initially when we are suspecting pneumothorax, or we want to rule out pneumothorax, right in the second intercostal space at the mid-clavicular line, and then we examine for certain things and compare, and then we move our transducer down until we reach the cosophrenic angle in this particular fashion, as you see here. And this is what we see normally. This is a linear transducer image, and this is a curvilinear transducer image. As you see, this is the pleura, this is the soft tissue, this is the pleura, this is the soft tissue here. You can notice that there is some sort of sliding motion of the pleura. This is called the sliding sign. You see it here too. So the presence of sliding pleura or sliding sign rules out pneumothorax beneath your transducer. And the second thing you see here is B lines. You see some sort of lines that start from the pleura going all the way down. You see them here more clearly. So B lines also is another way of ruling out pneumothorax. The presence of B lines makes pneumothorax extremely unlikely beneath your transducer. Here you can see an A line. You see it here too. A lines become more prominent in pneumothorax. Okay, so these are three important signs that you should remember. Now, the third thing or the fourth thing we can do is that we can do M mode, and the M mode basically will give us a distinctive pattern in normal lung, which is called the Seashore Sign. This is the chest wall, and this is the lung. And as you see, the chest wall looks like the waves of the sea, and the lung looks like the sand of the shore. So Seashore Sign is another sign of that rules out pneumothorax beneath the transducer. Now this is a patient of ours in whom we discovered the pneumothorax using ultrasonography. As you see, this is the right chest, this is the left chest. In the left chest you see there is sliding here, but you don't see it here. You see B lines clearly, you don't see B lines here. Of course, this is, if we made this deeper, somehow we may see the A lines. And when we did the M mode, you could see that here you see clearly the Seashore Sign, while here you see something else. It's called Stratosphere Sign or Barcode Sign. This is another definite or important sign of pneumothorax. The most reliable sign for pneumothorax is this sign. This is called the lung point, where you see sliding in one side, no sliding on the other side, B lines in one side, no B lines on the other side. This is, in fact, the lung point where it marks where the pneumothorax starts and where the lung ends. For lower chest ultrasonography, looking for pleural effusion, collapse, consolidation, or congestion, we can use the curvilinear array transducer or the phased array transducer. And this is one for patients in whom, in fact, this is a normal subject in whom we are demonstrating something called the curtain sign. The curtain sign is nothing but air in the lung at the cosmophrenic angle that moves in and out of the way of the transducer, giving the air artifact. So the presence of curtain sign rules out pleural effusion at the cosmophrenic angle. Now, this is a patient of ours in whom there is what looks like bilateral pleural effusion. And when we put the transducer on the right side, we could see that there is the liver, this is the diaphragm, and this is fluid between the liver and the diaphragm in the abdomen. There is no curtain sign. What you see, in fact, is pleural effusion and collapsed right lower lobe here, as you see. So this is a large pleural effusion. So this is how pleural effusion looks like. So sometimes the pleural effusion has certain densities that we will talk about later. This is how we do ultrasound-guided pleural tap in a dynamic way. This is the needle, this is the transducer. This is, I'm just doing it in a phantom. And you could see that the needle is starting here. This is the collapsed lung, here's the diaphragm. And this is the needle going in and reaching the pleural space for fluid aspiration. So this is the tip of the needle, this is the partially collapsed lung. So as I've mentioned, ultrasound can show you the type of fluid you are dealing with. In particular, if there is septations or loculation. This is early septation or loculation, a patient with pleural effusion right side. Now, patients with ARDS or severe pneumonia, you may see another sign called the tissue-like sign. Here you see the liver, you see the diaphragm, and here you don't see the curtain sign, you don't see pleural effusion, you see instead something that's similar to the liver. This is called tissue-like sign. It is a sign of consolidation, basically. Now, in pulmonary edema, you will see plenty of B lines. So as you see here, plenty of B lines, quite visible B lines. This suggests pulmonary edema. Now, moving further to abdominal ultrasonography, we use here mainly the curvilinear array transducer. If you don't have curvilinear array transducer, you can use the phased array transducer as well. And basically, we do systematic examination. We examine the right upper quadrant and left upper quadrant, looking for Morrison's pouch in the right side, Splenorenal Recess in the left side, and looking again for ascites anywhere. I will not talk about abdominal aorta, kidneys, or stones. And then we examine the pelvis. So the way to examine the right upper quadrant is as follows. We put the transducer right at the right costophrenic angle, trying to image the diaphragm, the liver, and the kidney beneath it. And we then sweep the transducer down, examining further structures. The reason why we examine the Morrison's pouch on the right side is to look for fluid, because if there's bleeding after trauma, for example, blood has predilection to the Morrison's pouch or splenorenal recess around the liver tip and also in the pelvis. That's why we examine these particular locations mainly. Left upper quadrant, we do exactly the same. We put the transducer trying to view the diaphragm, spleen, and kidney, and then we move the transducer downwards. In the pelvis, we prefer to do longitudinal approach with the index mark pointing towards the patient's head. By the way, always keep the index mark pointing towards the patient's head. And we view the bladder and the structures beneath the bladder. So let's start with the right upper quadrant and Morrison's pouch. So Morrison's pouch is located between the liver and the kidney. It is a potential space where fluid has predilection to accumulate there. This is how we do the examination, and this is how it looks like. So this is the diaphragm, this is the liver, this is the right kidney, and as you see, this is Morrison's pouch. There is nothing there. There is no black shadow in there, which means that the patient doesn't have fluid at this particular location. Now this is a live image of Morrison's pouch. You see this is the right kidney, this is the liver, and as you see Morrison's pouch is quite clear, there's no fluid in there. And this is a patient, post-trauma patient, where there is black shadow at the Morrison's pouch. This indicates that there is bleeding intra-abdominally and the blood has reached the Morrison's pouch. This is another image showing fluid at the Morrison's pouch. Now, Morrison's pouch is also called hepatorenal recess. On the other side, we have no Morrison's pouch, we have the splenorenal recess, where you see the diaphragm, the spleen, and the left kidney. This is the splenorenal recess. And this is another splenorenal recess, although the spleen looks big here. This is a live image of normal splenorenal recess. There is no fluid there. And this is an image with fluid at the splenorenal recess extending downwards. Now going to the pelvis. In the pelvis, what we do is that we examine the urinary bladder. The head is towards this side, the legs are towards this side. This is a man. This is how the transducer is in fact oriented. This is the bladder filled with urine, and here you have the structures beneath the bladder like the rectum, etc. This is a female. By the way, the previous one is normal. This is a female, this is urinary bladder, this is the uterus, and beneath the uterus is the rectum. Now, the space, the potential space between the bladder and the fundus or the ureter is called vesico-uterine pouch or pouch of Douglas. And fluid can accumulate either anterior to the uterus in the pouch of Douglas, or behind the uterus. As you see here, there is free fluid. In men, it may accumulate basically behind the urinary bladder, between the bladder and the rectum, and this is called rectovesical pouch. Now, the last thing I'll talk to you about is ascites. As you see, these are bowel loops swimming in a pool of fluid. This is acidic fluid basically. So there's ascites, as you could see here. And this is how we do acidic tap. Oh, sorry, before that, I want to show you acidic fluid with the septations. So this is a complicated ascites. So there's intense inflammation there that resulted in multiloculated ascites. And this is how we do paracentesis, ultrasound guided. You see the needle going in, then the needle went out, and what remains is the cannula, and then we can spray fluid for either analysis or for therapeutic purposes. Thank you very much. I hope it is a useful presentation, and I may produce another presentation for echocardiography. Thank you very much.